Afternoon. I'm very happy that not all of you left us. And I actually would like to come back to a cliffhanger I had before the break. And this cliffhanger was Pirko's quote, like flying to the moon, or rather flying to the Mars. Because the whole story is nobody would have ever flown to the moon if it would not have been up to the women of color, which were the hidden figures, and they eventually got known as the hidden figures by a book or even by a movie recently, because it was them who were able to calculate how the rocket could go up to the moon and come back again, including the astronaut. And the astronaut wouldn't enter the rocket before it was not made sure that one of the women, or a special of the colored women, of the women of color at that time, checked all the figures. And this was time of segregation in the States. So the main problem for the women was to find a toilet. So much for that. I would recommend that everyone, or if somebody has got the chance, look into the movie or look into the book. And thank you very much for sharing that with us, Pirko. Now, we will start with our next session in the afternoon. You can still put questions on Slido, and we will do our best to answer them, but we cannot promise. Anyway, this panel is going to be about health, and Zuzana Madarova knows everything about health, so I would like her to make the presentation. She's from Slovakia, and she's part of the EIGE team since 2015. And EIGE is very grateful to Slovakia for sending this expert as part of the team. So thank you very much, and let us hear your presentation.
Thank you very much for the introduction. Good afternoon. The aim of my presentation is very simple. I will use data from the Gender Equality Index to show why we need to bring gender to the heart of health policies. And as with every other big topic, we can start from ourselves. So let's think a little bit. What we ate for breakfast today. And forget about digital technologies now. Raise your hands if you had vegetables or fruits for the breakfast. Okay, that's good. Can be better, but that's fine. I will not ask how many of you had coffee and a smoke. Okay? So, the World Health Organization recommends to eat 5 portions of vegetable and fruits per day. It doesn't really recommend smoking or drinking alcohol, but it recommends physical activity, aerobic physical activity, running, swimming, cycling, and other types of aerobic physical activity for at least 2.5 hours per week. So these are the recommendations. This is some kind of guideline so we can see what is the health enhancing behavior and what is the risk behavior. And this is actually what we are going to see now, what we cover in the Gender Equality Index. And even though that risky and health enhancing behavior is quite clear, we actually do not really behave accordingly or act accordingly. And this behavior is very gendered. So, for instance, in the European Union, we know that men are more physically active than women, but they also smoke and drink more. Let's look a little bit closer. Why is it so? It's because health behavior is not only about individual choices. It's not a matter of individual decision. Of course, partially it is. But it's also very much influenced by by expectations, by socialization, by gender norms, by the things what we expect us as women and men to do, how we expect us to behave, and what it means to be a proper man and proper woman. It's really much, it is very much related to masculinities and femininities. So, for instance, the place where I come from as a boy, you understand quite soon that as a boy you should eat proper meat for lunch, right? And another portion as a dessert, because it's not enough for you to eat vegetables or fruits or something lighter. And you also understand very soon, unfortunately, that if you say no to a drink, you're probably sick, because there are no sufficient reasons, no other sufficient reasons for not having one or two drinks. And if eating fruits or vegetables and having proper behavior that is health-enhancing is actually a threat to your masculinity, then maybe it's not very surprising then a half of men in the EU smoke or drink alcohol extensively. If you compare it with women, there is a big gender gap and gender difference. And it is very much related to gender norms. Then, for women, implications of gender norms are very different. So let's imagine that the image of a modern woman puts a lot of pressure on women these days. Women that many of them are working, are employed, and at the same time, they are primarily responsible for childcare, for households, for taking care of all the unpaid work. And it is actually this context that we need to see. And we also know from the domain of time that women have less time for social activities, for leisure, for going to the gym, for going to the theater. And this is actually the context we need to see when we say that men are more physically active than women. Then 1 in 5 women in the EU meet these recommendations of the World Health Organization that I mentioned in the beginning, and 1 in 3 men. And this is why we need why we need to bring gender to the heart of our health policies, to understand where these differences are coming from, to understand the root causes of gender inequalities in health, to be able to address them properly. Now, today we were offered a nice lunch, but usually we provide food for ourselves, for our families, for our dears. And gender comes together with other factors that influence what we actually eat. For instance, it matters if you are a woman with 3 children working for a minimum wage, or if you are a person with a disability that cannot really reach this fancy and maybe very healthy place because the stairs are just too high. So there are different factors intersecting with the gender that impacts our dietary options, but also the overall health status, our overall health, also our access to healthcare. And it also impacts when we die. So in the European Union, men live more than 5 years less than women. Sorry. I forgot about the scores of health behavior. I'm so into the stories, I'm sorry. So this was the very important moment because the health behavior that I described in the beginning, it is the first time part of the Gender Equality Index. So for the first time, thanks to the European Health Interview Survey, we were able to cover this domain and actually talk and analyze behavior of women and men in terms of health. And we can see that the best performing countries is in this subdomain. By the way, the subdomain that is the lowest one in the domain of health. So the best performing countries are Sweden, the United Kingdom, and Austria. And the three countries with the biggest room for improvements are Romania, Bulgaria, and Lithuania. And now I will go back to the way how women and men in the European Union live. So what I wanted to say was that men in the European Union live more than 5 years shorter than women. In some countries, because there are many differences between member states, in some countries the difference is around 10 years. It's Lithuania, Latvia, and Estonia where really the difference in life expectancy is so big that it reaches 10 years. But we cannot really say that women can enjoy their longer lives, because the fact is that they spend a lot of years in ill health, more years than men. Can you imagine that women, on average in the European Union, live 20 years in ill health? That's a life of an adult person. So this is also something we need to consider when we talk about life expectancy and quality of life, because quality of life matters. And also it matters because the society is changing. We live longer. We have more people that are more experienced, that are more knowledgeable, but also they face challenges in terms of health. And it is striking that in the aging society, only about half of women in pre-retirement age feel good about their health. Many women and men with disabilities faces these challenges, that very few of them feel good about their health. And the biggest gender gap that we can see in terms of self-assessment of health is actually between women and men with low qualifications. We see then less than half of women with low qualifications assess their health being good in comparison to 60% of men. This is also a huge gender gap and something that can be addressed by proper policies. And this is exactly why we need to bring gender to the heart of health policies, to improve life of women and men in the EU, regardless of their age, regardless of their level of education, of their migrant status, because it should not really matter. The third area I would like to talk about is about access to health. And let me tell you that talking about index and all the indices in general, we very often talk about numbers, scores, points, and ranks. And we tend to forget that actually what we are really talking about are people's lives. There are millions of lives of women and men that are impacted with every deducted point. And we need to keep this in mind. In terms of health, it's really, some issues are a matter of life and death. Let's take example of the subdomain of the Gender Equality Index that has the highest score, and that is access to healthcare. Because there, it's very obvious. In general, the access to healthcare for majority of the population is quite fine. We measure it through unmet medical needs. So if you look at the general number, you would say that it's okay, but it's not true for all. We looked at different social groups, and we can say that the social group that face highest or the most barriers in access to healthcare and dental care as well are people with disabilities, women and men with disabilities. And again, the group with the biggest gender gap are lone parents. We can say that lone mothers face the highest barriers or the largest barriers in access to healthcare. Now, 12% of lone mothers in the European Union have unmet medical needs. This is half the number, or double the number when we compare it with lone fathers. It is also very important to say that access to dental care is even more complicated, because if you look at the unmet dental needs, then you can see that the number is even higher. We talk about millions of people. In the EU, there are more than 9 million of lone parents. And it's very gendered because 85% of them are women. So we are also talking about quite a different sizes of groups. And this is something that can be fixed. But we also see that there is another good reason why we need to bring gender and intersectional perspective to the heart of health policies. All the areas that I talked about, health status, health behavior, and access to healthcare, are covered in the domain of health of the Gender Equality Index. The domain that improved, like really about a few points, 2 points in 10 years' time. It's not enough. So if we want to start a way to happier and healthier Europe, we need to act. We need to do something because it's important. And what we actually do. I talked about premature deaths, and we know that millions of deaths can be prevented with better targeted, with gender sensitive, with good policies, with improving healthcare access. We also know that the aging population that has many challenges these challenges can be addressed by exactly including gender and intersectional perspective into policies. And, most of all, mainstreaming gender in health policies can improve lives of millions of women and men in the European Union. So, thank you very much.
Thank you, Zuzana, for your very, very nice presentation. And now I would like to ask for our next panel, Xavier Prats-Monné, DG for Health and Food Safety. He's from Spain and an active politician who fights for his topics. Welcome. We are glad having you. Sirpa Pietikäinen from Finland, Member of Parliament, and her topics are environment, public health, food safety, and her heart is with women's rights and gender equality, reproduction rights, and she's a real feminist for years. Okay. And we are also happy to have Vanessa Moore, who could make it on a very short notice. She comes from Ireland, from the European Institute of Women's Health. We are very glad to have you here. She's a senior researcher based in Dublin, and the Institute is promoting women's and family health issues. Thank you very much. So can I now ask my panelists for their interventions? Who would like to start? Yes, please. Thanks. Yeah, it will work.
Does this work?
Yeah, yes.
Yes. Hello, thank you. Well, I'm not here because I have something to say that you don't know. You're the specialist on gender equality. I'm here to say how important the Gender Equality Index is, because if I had to mention one single thing, particularly but not only in the field of health, I know education rather well also, since I was in education first. In health, more than in most sectors, the best thing we can do for gender equality is to provide more evidence about gender and health. This is why this is so important as a work. The question is, what lessons we draw from this, from policy? Perhaps the first thing to say is that let's start with the context. Huh? I mean, if, from the point of view of health, if you want to choose anywhere in the world where you want to be born, no matter what gender you are, but especially if you are a woman, then you would be Swedish. If that is not an option, then you would want to be European. Because from what we saw, you can see very well that while we still have differences and we still have a gender gap, health is a sector where equity is doing better. And that is because we still have in Europe welfare regimes that still provide universal access to healthcare. So let's celebrate at least that we are the part of the world where we are holding up with healthcare systems that still do a consistent effort to make sure that health is not just for those who can afford it, but who actually the health is a public good. Coming now to the situation of women in health, I think one striking thing, I mean, perhaps the most important impact on our future health policies is aging. And from the point of view of aging, the importance of gender differentiation is very clear. Every two men aged 65 to 80, you have 3 women. And every 2 men aged 80 or more, you have 4 women. So the impact of demographic aging on policy, which is huge, has a particular impact on women. So the more we do to take care of the needs of an aging society, the more we will do for gender equality too. Which also goes, I think, to show how important it is to bear in mind that gender equality, in health as in any other area, is not for the benefit of women, but for the benefit of society. Let me perhaps say also a few words about how policy can make a difference. If you take the most significant indicator of a health system's efficiency, you would take what specialists call amenable deaths, so deaths that are pointless and unnecessary, because normally healthcare systems should not allow for these deaths. And the most obvious one is perinatal death, women that die at or around childbirth. Now, if you look at the world situation there, you take Sierra Leone, the US, and Italy. If you want to find one poor girl that will die of childbirth in Sierra Leone, you just need to find a classroom. 1 girl every 20 will die of childbirth. You want to find the same girl in the US, you have to take an entire school. 1 girl every 1,800. You want to find that in Italy, and you have to find an entire village. 1 girl every 20,000 will die of childbirth. Now, what does it mean? Well, of course, in Sierra Leone, expenditure in healthcare is much, much lower than in the US. But the US spends twice as much as Italy on healthcare, with 10 times as less results in terms of animal death. So policy can make a difference. Money is not everything. And therefore, we have a very strong interest in having strong, solid data about the gender dimension of healthcare so that we can influence policy. I should end, I know we have to be short, I should end with a couple of particular points where the differences between genders are particularly striking. One is, by the way, not directly linked to healthcare, but the healthcare workforce. I mean, it is striking that in the one sector in our societies where women are really predominant, 80% of workers in health in Europe are women, well, there the gender gap in salaries is actually higher than the average. So it is pretty striking that we're still there. But then there is a couple of areas that I think are really a demonstration of a very profound fact, which is that the real determinants of health are not in health, they are in social inequality. Take mental health, for example. Women are far more affected than men by mental health, and I think that there's a very strong evidence. This is, by the way, a pandemic of our society. I think there's a very good evidence that the reason for this is that this is the dark side of multitasking. Women have too many obligations at home, with family, at schools, at work, and that means that their stress on them is far stronger. I think that we have to try to ensure, when we produce policies, that we look at what is good for the sustainability of our healthcare systems, and there's no way you can look at that without looking at what we do with gender. My last word is I said about the non-health determinants of healthcare, and I'll give you just one simple example. If you take the London Tube, the Jubilee line at Westminster, and you go eastwards, every tube stop, life expectancy decreases by 1 year. Especially the life expectancy of women. So if you are a woman, an adult woman born in Oxford Circus has a life expectancy of 97 years. Another woman born in Bowchurch, way up the East End, has a life expectancy of 77 years. Now that tells you a number of things. First, the differences are not just between countries, but also within countries and cities. But also that what determines the health of people, the health of women, is not the healthcare systems alone. It's poverty, it's access to information, it's education, it's socioeconomic conditions. And this is a demonstration that gender equality is something that is an objective for the entire of our society, but also for the field of healthcare.
Thank you very much for this really interesting input, and I would like to give the word to Sirpa.
Thank you, and first of all, I would like to thank EIGE for producing this gender equality index. I think that this is very important information, and hopefully you can broaden the work together in the future in the field of health, for example, or with our other institutions. This is a very multifaceted issue, and I'm going to touch only a few of issues. I fully agree with you that the most important issue is to have the universal public health care for all, because women are more often in vulnerable situations, in less favorable situations economically and otherwise. So if you want to do something in the women's health, start early and ensure the access to health care. And that means not only illness care, but health care and prevention. Second difficult part, of course, is, and that is an issue in some parts of Europe too, the right to reproductive health counseling and safe abortion. This is a very classical issue, but I think that we should have that on the line and not to forget that one either. The third, that was when I was making the report in the Parliament about this subject a couple of years ago, very striking to me, is the fact, and I endorse all what you said about the other factors, what is happening already, but then women's illnesses are less researched and they are underdiagnosed. Osteoporosis is a good example of that. Another one is heart attack, because the symptoms are different than what are the male ones. And doctors are learning the male symptoms and asking, do you have an aching pain in your left arm and feeling like elephant is sitting on your in your chest? No, I don't. I'm just having nausea and sort of a uncomfortable feeling here and there. And when they are not recognized, they are categorized as symptoms and psychosomatic symptoms. And that again, when you learn to be a doctor, you looked at, okay, with an elderly women, there's a high degree of psychosomatic symptoms. It increases the tendency to under-research and underdiagnose the women's typical sort of symptoms or diseases. And this might be a big part of this sort of under-treatment and poor condition of elderly women. And I guess we just have touched the tip of the iceberg in what categories the symptoms are different, what are those sort of female gender typical issues we should touch. Then the third that is a great interest to me is the newest sort of fields of research, that when they have researched the stem cells and other sort of physical procedures within a human being, the gender matters. So the reactions to treatments and medications and to viruses and you name it is different from a stem cell that is derived from a woman than a stem cell derived from a man. So actually we should demand that kind of a gender-based research in the future. And that, of course, then goes to the fact that if we look at our medical research, middle-aged or youngest men are overrepresented, and guess who is eating the medications? Women live longer. It is the elderly women, and they are seriously under represented in medical testing and all that. So we would need to look this whole healthcare system, the understanding of diagnoses, illnesses, medical treatment testing and all that, the gender classes, and so I'm looking very much on you. There's a lot of what we could do more, but we would definitely need to do it together as a Europe, and we would need to collect the information because Finland, Italy, France, no one can do it by themselves. So there are just few notions that I wanted to bring on the table, and yes, of course, then there are very much these kind of a societal issues and stereotypings and all that impact differently men's and women's health, and that's a very big part, but because you covered it very well, I didn't want to sort of repeat what you already took on the table. Thank you.
Thank you, Sirpa, for this very interesting and sharp analysis. Was health and gender connected? Everything is. And now, can you please...
So I'll just touch on a few similar things, really. First of all, Peggy Maguire, who was supposed to be here, sends her apologies. She's not, so I'll do my best to replace her. And also, just before I start, just to congratulate EIGE on a fantastic report. Great to have this evidence base. It's really something. Well done. So as we all know, differences exist between men and women across a lot of health conditions. Some are biologically based, some are more socially constructed, some are due to both issues, socially constructed or biological. Many of the factors that do influence health actually lie outside the health sector, where a person lives, education, employment, so on and so forth. They'll all affect a person's access to resources, to live a healthy life, vulnerability to risk factors, and so on. Understanding this interaction is very important, as you mentioned, to address sex and gender inequalities in prevention, diagnosis, treatment and care, and to improve health in both men and women, because it concerns both. Any failure to kind of acknowledge the impact that sex and gender does have will affect the quality of healthcare provision. Just using the same example as Sirpa did, a cardiovascular disease where being a man is considered the norm. Female symptoms of, for example, acute coronary syndrome are seen as abnormal, and so when a patient comes in with these symptoms, the doctors don't really know what's going on because it's not the norm, even though it's 50% of the population. Also very timely to mention reproductive health. There's, how can I put it, uneven availability across Europe. Even though most of Europe do have this right, some parts of Europe don't, so it's still a continuing issue for a couple of places, 2 or 3 places in Europe. So it is important to keep that issue going, because it's not freely available for everybody, and that also very much affects migrants, especially in countries where if they're in one of those countries and they have to travel to receive this treatment, they mightn't be able to due to visa restrictions or whatever. So it is a huge issue for everybody involved. In terms then of having this very solid evidence base that you provided us with is absolutely great. Also the issues that Sirpa mentioned of clinical trials and kind of the evidence of the differences between men and women biologically. The AIGE, we've worked a lot around this over the past 20 years, and we worked with other organisations and stakeholders to promote gender and age to be systematically included in the new clinical trials regulation. So the fact that the clinical trial now has to be representative of the population group that it's studying, that the results now must present age group breakdown and gender breakdown, and that provision for including and protecting pregnant and breastfeeding mothers or women participating in clinical trials is very good news for women. Women have traditionally been underrepresented in clinical trials. Consequently, the evidence base has been weaker for them. You take medication that actually has been tested on a middle-aged man, but you might be an older woman or a younger woman or whatever. The underrepresentation in clinical trials also affects older people, men and women. So it's great to have them, that it'll be an age layout as well. So we really hope that this legislation will strengthen the protection of patients and clinical trial subjects, and to streamline the clinical trials process in Europe. That will bring more evidence-based medicines to the patient faster, while providing greater protection for them, and also that it will be more effective. Implementation of sex and gender into research protocol will ensure that both women and men's health issues are considered from the start. Sex and gender considerations in biomedical and in public health research is very important, as is applying this knowledge then from the research to create a more targeted prevention options. And research and data analysed and disaggregated by sex, age and gender will provide such valuable information for policymakers, programme managers, just to develop a targeted specific healthcare and treatment. Another issue then in terms of health and health policies, obviously, as we mentioned, gender mainstreaming, which is really important, and it needs to be implemented across all policy areas, like I said before, and like we all know, health isn't factors that influence health aren't necessarily always health related, social, economic, educational, cultural, whatever. So these must all be included in development of policies and programs with an intersectional approach. So really everything you said. Just again, using the example that's been mentioned a bit throughout the day, women in pensions. Women have a lower pension because they maybe have a lower participation in the workforce, they took career breaks or went on a lower part-time employment because of obligations, maybe for caring for an older relative, childcare demands, especially in countries where childcare is prohibitively expensive. So this obviously a lower pension in older age will mean you're more likely maybe to suffer poverty. That will have a detrimental effect on your health and so on. Another issue, again touched on by Sirpa, is education in the medical curriculum. Gender and sex differences must really be mainstreamed in all medical and health professional curriculums, not just doctors, but nurses, pharmacists, allied healthcare professionals, anybody really involved in the healthcare services, just to ensure that it becomes a natural part of healthcare. Transforming the medical curriculum has to be a key measure for building capacity of healthcare providers to have some form of gender analysis and responsiveness. Historically, medicine, medical education, it's considered, again, male, being a man is the norm, male physiology is the norm, women being underrepresented in illustrations of anatomy medical textbooks, obviously non-reproductive ones. This has led to the neglect of the importance of sex and gender in explaining differences between men and women, and it's also contributed to this gender-based inequity in medical treatment. So, yeah, that was just in summary, just a brief mention of a lot of issues, but basically gender awareness, gender mainstreaming, intersectionality really needs to be part of all policy initiatives and intervention if we're to move forward and actually make a change and contribute to something.
Thank you, Vanessa, and thank you to all for all your deep and really striking insights of health and gender relationship. I want to make a round of questions, and I noticed that you have noted down something already. But anyway, I was going to ask you, what did out of the report strike you the most, and what would you like to change the first?
In the report or in the situation?
In the situation. Thank you.
Yeah, well, actually what struck me most in the report is that is what we call in our jargon the need for a One Health approach, because the report is by sections, as it has to be, but it's very difficult to look at how to improve, never mind how to analyze, but how to improve gender in health without looking at the social determinants of gender. And you mentioned, what I was noting down is something I forgot to mention, but is extremely important, which is sex and reproductive health. This is something where we are, again, further ahead than any other part of the world, but we're not there yet, and we should not actually go back. And I just want to be on the record on that. So for me, it's important to make sure that it's not just health specialists that discuss health. I'll give you an example. WHO does fantastic normative work for the whole world on health. And they say a lot of things about the determinants of health, smoking, obesity, etc. but they don't say much about poverty, which is the most important health determinant after tobacco. If you are poor, you die sooner. It's just as simple as that. And yet, WHO doesn't have a mandate, so it's not that they are not aware of this. They perfectly are. But we have too much of a compartmented way of policy making. And our efforts, certainly in my DG and my commissioner, is to try to introduce health in other policies and vice versa. This is, I think, the most telling lesson, not because it's the most striking, because maybe it's not the most obvious immediately, because it's not just one figure, it's one policy conclusion. What I would like to change most is linked to this. I mean, in Europe, actually, we don't have a glass ceiling. We have a big fat layer of men that are still standing on the way of women. It's different because it is habits. It is the way you look at the patient that has to change, more than manuals or money put into policy. And I think that it is by changing mindsets that we'll make the most progress. And I think that producing evidence about the impact of gender on health and vice versa is the way forward. And this is why I just want to insist that this should be compulsory reading for anybody who is working on health, certainly in the Commission.
I think that's a very good advice. And Zuzana would like to make a comment on that, please.
Yes, thank you very much for bringing this up, because I think it's very important to say that what we're really aiming at the index is to see how the different domains are interconnected. And actually, I mentioned some of the issues in the presentation, because yes, we see how the domain of health is connected to the domain of money or to the domain of time, domain of work. So actually, yes, like all the other domains can be understood as social determinants of health. And it is very important to make the synergies between different policies aimed at different areas and make sure that they support each other. So thank you.
Okay, thank you very much. And Sirpa, I was going to ask you another question, because I was quite happy that you brought abortion into the discussion, because I think this is really a main issue in the health and social policies of all the European countries. I'm sure that we didn't get any deeper insight into that, because there are no data to be compared amongst the different European countries. But still, I would like you to go a little bit into this sort of matter.
Well, of course, just to mention that the maternity health and is other issues too. Just want to raise the endocrine disruptors that actually has the worst impact on the pregnant woman and on their descendants. So there are that kind of agenda issues too. But then when we go to reproductive health and abortion, I think that the alarming scene has been that actually in the Europe we have seen some drawbacks and in globally on debating on this. And it should be a very essential part that everybody has right to their bodies and everybody has right to their sex and their sexual preferences. And part of that right is the right from early adulthood for advocacy, birth control, and also this is a bit side story, but nowadays it is advocacy and help if you are a transgender person or if you have other that kind of needs that are widely unmet at the time in our healthcare systems in the Europe. And somehow I would have seen that this is this kind of a self-clear human right, health, gender issue that we fought 20 or 30 years ago. And then seeing these developments nowadays, for example, in some of the Visegrad countries is very, very depressing and very alarming to me, because they are alarming as an issue per se, but they are, to me, a strong signal about this kind of gender discrimination too. It does not matter, because it is totally a women-related issue, and that's why it is an issue we really should fight strongly back.
Yes, Of course.
Just very briefly to say that I agree 100% with everything you said, and some countries things have rolled back a bit. Some countries just never ever actually got started on the process, and so when you have a situation where EU citizens are face being put into jail for 14 years for importing illegal abortion drugs, that's really not acceptable. And it's really something that needs to be continue to be highlighted, because you'd think in this day and age. But yeah, thank you.
Can I add one thing very briefly? This is about transborder healthcare systems. I think that it should be very clearly stated out there that abortion and reproductive healthcare should and is part of this transboundary healthcare systems, where all the people who don't have the access in their respective countries should be able to seek the treatment and advocacy in some other EU member state.
Thank you. And I would like to come back to the first part of your answer before, because we did have a question out of the audience before, but I think it's now a good timing to get it into the round. And the question was, isn't it time to remind gender equality in the EU policy not only as a matter concerning women and men, but also those who don't identify with either? So, anybody would like to respond?
I can just respond briefly just to say, I mean, absolutely. It's a very well posed question and a very correct question. You need to recognise the fact that gender is actually non-binary. There is a spectrum. And I think, again, just to have awareness of that, even the confusion that often exists between the two terms, sex and gender, a lot of people can't really grasp that when you go out to, a lay person, and they might not even understand what's the difference, and then never mind trying to understand if people don't identify as being one or the other. So it's really important to keep that in mind and to raise awareness of that. And even again, in terms of, say, for example, medical education, that becomes part of it as well, to recognise that is, it's a very valid form of expression. If you don't identify as male or female, that's absolutely fine. You identify somewhere in between, and that needs to be taken into consideration. I don't know, did you want?
Yes, and I think that is self-evident. And actually, when we have these reference centers in the health area, we should have a reference center for LGBT people also. And this is one part. There are special needs that are unmet at the moment, but then the other part is this kind of a stigma in some of the professionals. So even though if you would have a flu or whatever cancer, you might not be able to get proper treatment, or you are not willing to go to your doctor because you are laughed at and you are discriminated and issues like that. So it is a preventive factor just to the normal healthcare for many people.
Very good.
Yeah, I think from the Commission point of view and also my personal point of view is that this is just another form of discrimination, and we should not allow any kind of discrimination. To me, it's just very simple. Yes, I agree.
Now, thank you very much. Now, I would like to draw the attention to our audience. Maybe there are some questions. Okay, there are some questions. Where to start? Maybe with you? Could you introduce yourself?
Is it on? Yes. Hello, my name is Annika and I'm from Social Platform. So one of the umbrella of NGOs that has been having the opportunity to input the index. And that goes without saying that the index is extremely useful both for us as organizations, but also, of course, for the policymakers. I just wanted to connect back to the last question that you just posed, as well as to the previous panel, which was on intersectional inequalities. And I think my first point is that, of course, we know that the index itself really needs comparable data. So there are gaps today on what can be covered by the intersectional approach. Although I think these type of questions needs to be raised, just like they are raised in the discussions today, but also by EIGE and by the ones of us that kind of take part and make use of the index. And I think one of those groups that was mentioned now was talking about gender identity and transgender. And I just noticed that our member Transgender Europe just posted a report online of a few countries showing that more than 60% of the group feels too afraid to even seek health care. That means that you don't even go to the doctor when you're sick, no matter whether you then, if you go, get the right treatment or not. And it's an extremely high number, and we know that similar figures we have in the Fundamental Rights Agency's reports as well. So I think that's really worth taking into account. And I don't think, as Sirpa said, I don't think it is self-evident. We really need to speak about it, because I think few people know what transgender people, who they are, and what type of barriers they face, both in terms of discrimination and actual barriers that could be solved otherwise. Another group that was mentioned in the previous panel was migrants, and nationality was one of the variables that was possible to cover by the intersectional approach, and that's of course really good. But to not forget the ones with the migrant background, so the second and third generation that live and have the same nationalities as any other European, but where the ethnicity is the issue and where racism is the issue. And I think that's also something that cannot be covered today, but knowing that we're welcoming refugees, some of us at least, and migrants, this will become more of an issue, and we need to speak about the whole population. Thank you.
Thank you very much for this very valuable input. I think we can go on, because we have so many people wanting to ask. Please.
Hello, Chris Brooks from the UK Health Forum. I'll try and be succinct but high level. Firstly, it would be really useful if in the next Gender Equality Index you capture the fact that actually many of the issues that were captured earlier contribute towards health. So we've clearly heard you say that housing, employment, poverty, indebtedness, air quality, environment are all important issues, and they're captured in many ways in the health. So that's the kind of the request. If you can build a kind of a descriptor of some kind or a framework that brings it together in the health bit. The second bit, in case we lose it, is you spoke about smoking and alcohol consumption and fruit and veg. I'll talk about junk food. We might want to reflect that if you're talking about what I would call health behaviours, which you also used, then you're not trying to level up. You're not trying to, I don't believe, get women to drink at the same levels as men and smoke at the same levels as men, but level down. So it's actually therefore, and the point is, to think about the role of perhaps constraining on health commodity businesses, those that produce tobacco, alcohol, junk food, and providing information to the consumer about the potential harms from such products. And of course, that impacts more on women in many cases than on men. So it needs to be thought through, but I'd make that kind of point about unhealthy commodities.
Thank you very much for your very valuable input, and I would like to give to the lady. It is.
Yeah, this won't work. Thank you very much. My name is Isabel Duarte, and I'm the gender advisor in the World Health Organization in the Regional Office for Europe. I would just first like to fully support what the previous speaker had said, and first to congratulate that there has been a huge effort on trying to make this version of the health domain much more relevant and significant, and that's not an easy task. The other one, it's like that measurement of equality. I fully support it. I think that, unfortunately, I couldn't be here because actually DG I was in another event that was presenting a lot of the research that is being done on gender and health, both by DG Sanko with the GenCat project and also DG Research. So just to say that there are clear guidelines on how to use gender in research that the European Union projects are using across. But also that WHO has made a huge effort on bringing gender into health policies. We did have the Women's Health Report from a gender perspective and a strategy approved last year in our regional committee. And we are looking at the Men's Health Report and a strategy from a masculinities perspective from the next one. But complementing what he said and the previous discussion about sexual and reproductive health, we also look, I think that there should also be some part of the domain that even if it is not the same methodology because we cannot have systematically sex difference collected data, sexual reproductive health and rights are at the core of gender inequalities. There must be a way that within the next version of the Gender Equality Index we can address some of the issues, even if it is looking at unmet needs of contraception or some of the key relevant indicators that can be used. And then the last one, just because of a reference, we do work on health and poverty. Actually, it's not our main, but we are making a huge effort to addressing the social determinants of health and bringing health into poverty reduction strategies, which is not an easy because of the role of the ministries of health at the country level. But thank you. I think it's really a good progress. Thanks.
Okay, we want to have thank you very much. Very, very valuable input. We have a short reply on that.
Very short comment. This commission didn't publish the health program, so it would be appeal to all of you that we would work together and work with EIGE and others to have with the next commission, because I know commission has been doing a pretty good job and there's the willingness, the work there that we would have the work program, and there we would have the patient rights, we would have the bottom-up approach, we would have the right for e-health, we would have the importance of the public health services, and the poverty link, what we discussed, and this gender as one of the main issues. And so it might have the impact. It is the member states that are pulling against and not willing to give that kind of a competencies on European level. But if we do not work on the European level, it is even harder to work out these issues in Poland or in Ireland by themselves.
Yes, that's Europe. We come to another two questions, and then we make a final round for the panel.
Thank you. My name is Anne Lenoy Marlière. I am from France, from trade union CGT. And at this stage, I would my view is that we cannot we cannot say that violence against women can be called discrimination. I would rather say that it is a human rights violation. And and I think that it happens in almost all social categories and age, not only in migrants, family or else. I think it happens in any social and aging at any age. Of the European population. So in a private and public life, at work, in political life, and in family life. And so my question is, the institute did the institute think to make measurements on the impact and long-term effects of violence and sexual harassment on the women's health? And this morning we spoke a lot of the intersection.
You want?
sectoral inequalities and effect on the competitivity. So my question is also whether we can measure the long-term effect on the women health and the obstacle it makes on their progress in the professional life and in their public empowerment. So the effects of the violence generally and the sexual harassment. Thank you.
So, Zuzana? In terms of violence against women and more information about... Try it again. Okay, now this should work. In terms of violence against women and the consequences of violence on women's health, this is part of the measurement framework on violence against women in the domain of violence that will be revealed in November. So all the indicators and the whole measurement framework will be better introduced in November, and we also consider the severity of violence that is related to consequences on women's health. So yes, it will be part, and it will be a separate publication exactly on the satellite domain of violence with more information about this.
So that's how the question is how considered and how very separate question this is going to be. And now I think I'll take one more question or two.
We have a question here. Oh, sorry. Yeah.
I'm confused.
Okay.
No, okay.
My name is Kerstin Setil. I work at the Swedish Secretariat for Gender Research. I just wanted to go back to the question we had before about people who don't identify as male or female, woman or man. And like everything we have been talking about today is based on only men and women. And I wonder, when do you think the Gender Equality Index will talk about other gender identities? Because if other gender identities are invisible here today, I don't think that will help the cause of improving the health of all these people. So when will the Gender Equality Index have more than 2 binary sexes?
That's a very good question, and this is the discussion that we are having for a long time, and maybe even from the beginning of the index. So this is not something that we haven't considered. But of course, as it is as we mentioned in the intersectionality part, and in many other domains that we would cover, we have issues with data, and Gender Equality Index at this moment can be only built around women and men, because we use data that are available, and only after some things will change. We can use index to open and facilitate discussion, but I cannot answer when it will be possible to have more or to include other gender identities or even consider in the index because of these issues.
I think this was a very good answer to this question. So maybe one more question? 2 more questions.
My name is Jan Reinders. I work as an activist in the Global Man Engage movement, which is a movement of women and men around the world for gender justice. My question is for Zuzana, but perhaps others may want to respond as well. When you started your introduction about smoking and behavior by man and the life expectancy, low life expectancy, I was wondering in the rest of the story whether you have included male healthcare seeking behavior in the study. And I'm asking this because when boys are brought up, they're brought up to be tough. Boys should not cry. Come on, you're a boy, don't cry. Now, if boys are brought up that way and later they're told by their peers, and that's, you've referred to peers as well, that rough and tough behavior is the norm, you don't want to go to a doctor neither for your physical health or your mental health, which means you'll work with diseases much longer, and that's evidence all over the world. I mean, there's enough evidence there. And I'm just wondering whether you've included that in your survey in terms of the health-seeking behavior of man as one of the issues that may actually lead to earlier death.
Well, we did not really do survey ourselves. We use data that are available. But we mentioned this exactly in terms of masculinities and femininities that are influencing behavior, and exactly this is one of the very good examples. So even if there is no indicator included in the report, that is a very important part of the analysis. And maybe I didn't mention it explicitly in the presentation, but that's exactly what I was aiming for, to make this connection not only with drinking and smoking, but also this is a very important part. If you are raised to be tough, not to complain about or not to talk about things that hurt, then of course it impacts your whether you are going to seek access to healthcare or not.
Thank you. And our last question comes. Okay.
Sorry, thank you very much. Mary Collins from the European Women's Lobby. I'd like to come back to the issue of the environment and ask you if in the future, the next gender index, that there could actually be an environmental determinants of health. And by environment, I mean we need to look at chemicals, fertilizers, pesticides, and the impact that they actually have on women and men's health, because they're also core to our economic model. So there are obviously financial implications, but if the index is about making changes in the long term, and we can actually establish that the way our mode of production in terms of chemicals, fertilizers, and the impact that can have, there's obviously issues for outside of this room, but I think it would be really very, very helpful to have those correlations between the two. And then finally, I think there needs to be perhaps a much stronger link between the consequences of violence against women in terms of stress and trauma and linked to health. I know it's probably there, but it's not very visible. And I think this is where violence against women as well can actually be strengthened in terms of giving you more visibility throughout the different indexes in the index. Thank you.
Thank you very much. We now have heard so many different approaches and ideas and insights into our topic. Now for the last round, I would like to ask our panel here, as health is the precondition for everything, what do you think has to happen now? No.
Well, I guess I used my intervention already. I hope you have resources and can develop the gender equality index further, and together with other institutions and in this health area. And I was just checking what is the state of the art of the EU health program. It is up and running up to the 2020. So the question is, as said, because this commission didn't prepare the new one, so that we would all work, that the next one would be very much having this gender focus there.
Thank you.
We're working on that. Well, I take a very practical view. For me, what is really extremely important now, precisely thinking of the future, is not to define what is important for health, but what is important for health and has absolutely to be addressed at the European level, because at other levels it cannot be addressed, or by somebody else cannot be addressed. If you look at the issue like this, you have bad news and good news. The bad news, in a way, is that there's many issues that are relevant, but that Europe perhaps doesn't absolutely need to tackle. For example, it's much easier to see, you can imagine, for example, that we could have a stronger partnership with WHO, which has a European region. WHO is a normative institution, so for non-communicable diseases, for example, how much sugar people should eat, what guidelines for alcohol consumptions, WHO and countries do a great job. Maybe there's a role for the EU, but I can see a far clearer, and that is the good news, far clearer, stronger role for the EU in anything that is cross-border and that is communicable. Because you cannot really justify working just country by country on Ebola, on communicable disease, on HIV, and so on. So the trick for us, and it's a difficult thing because Because the temptation of the Commission, as anybody else who believes in policy, is when you see a problem, tackle it. But then the challenge we have is to overpromise and underdeliver, and that's terrible. And we've done it in the past. We have identified many issues where people say, yes, this is a problem, and then what does Europe do for you? And maybe we don't have the means. That includes some difficult problems. I mean, we discussed briefly sexual reproductive rights, abortion. We have to be, I think, extremely forceful in these areas when the EU has a right to act, because the treaties give us a right to act. This is the sort of challenge that we have. And I believe, I hope, that there is real scope for a strong health program for the future if we are capable of making a distinction between what is important per se and what has to be done at the European level. And there's a wide scope for doing more also from a gender perspective, especially if we have evidence like this that shows that policy must be put in place, that policy can make a difference, that it's not just about money, and that you have the evidence to show that it has to be also gender-based.
So thank you very much. I think a lot of things can be done and hopefully will be done. From a practical point of view, would you like to say something?
Yeah, I'll just be very brief. I know we've gone over time. Just to echo what's already been said, I mean, absolutely keep, all policy to keep it, to keep all health policies really on a gender mainstreaming, to really put gender at the centre, because it has to be if it's going to make any form of difference, if we're going to make any form of progress. And I mean, I know again this morning when we did the little poll and people were saying they were depressed, they were disappointed. I mean, of course it is disheartening that we haven't made massive advancements, but we just have to keep on trying. And I mean, at least now we have an evidence base to say, hey, what we've done so far actually hasn't really done much, and actually some parts are going forward, other parts are regressing, some parts are going forward because they were so low to begin with anyway. It only could go up, it couldn't get any lower. So it's just to keep on emphasizing how important it is and really to put it at heart of policy.
Okay. Thank you very much. Thank you very much for the report. Thank you very much for the panel. Thank you very much for the audience. Thank you. Thank you very much. Thank you, Sirpa. That's great.
Last panel of the day. I'm aware that it's been a long day, but keep it up. There is some really interesting discussion coming up. So now in the last panel, we will focus